Today we'll be covering Chapter 40. This covers zoonotic diseases. Zoonotic diseases are those that can naturally jump from animals to humans. Transmission can occur via different routes. These routes include vectors, skin to skin, through animal bites, inhalation of respiratory droplets, ingestion of contaminated animal products, and via foodborne or waterborne routes. According to the CDC, more than 6 of every 10 infectious diseases in people are spread via animals. Some infections occur naturally in their animal host populations and then are subsequently able to jump to humans. In other scenarios, human-to-human disease transmission is also possible. In some infections, humans are the dead-end hosts. Since there's a large amount of material and various zoonotic agents and infections that can be covered, the way this chapter is divided is via the transmission routes. So there's 3 transmission routes with bacterial examples that are highlighted in each area. So the transmission routes include animal scratches and bites, direct contact or inhalation, and the last one being arthropod vectors. So first we'll talk about scratches, bites, and other contact with domestic or wild animals. The first infection we'll talk about is pasteurellosis. This is an infection that we discussed previously, with the causative agent being Pasteurella multocida. Pasteurella is a pleomorphic gram-negative rod that can be found in the oral cavities of most dogs and cats. This organism can pose as a primary pathogen or a secondary invader. On the right, you'll see plates with Pasteurella growing in culture. So there's a blood agar, a chocolate, and a MacConkey plate. And you'll see that there is growth on both the blood agar and chocolate, whereas there is no growth on the MacConkey. When Pasteurella grows in culture, the colonies typically appear gray, and the biochemical testing results are typically catalase positive, non-modal, they ferment glucose, and most isolates are oxidase positive. The most common clinical manifestations of Pasteurella infection include cellulitis and blood drainage from the bites or scratches from dogs or cats. Typically, cat bites or scratches are more common than dogs, and in most cases patients are afebrile. They have inflammation at the infected site, but no inflammation of the lymph nodes. Pasteurella can also cause infection by animals licking wounds. Rarely can infections occur in the absence of scratches or bites, but if an open wound is present and an animal licks it, then infection can occur. Other clinical manifestations of Pasteurella infection include pericarditis, corneal ulcers, upper and lower respiratory tract infections, endophthalmitis, and GI tract infections. Also, some other clinical presentations that occur more rarely include sepsis, meningitis, septic arthritis, peritonitis, and osteomyelitis. The next clinically relevant infection caused by bites, scratches, or wound infections include erysipeloid. The causative agent of this is Erythropelothrix ruthpathiae. So you remember we discussed this briefly as well. It's a thin, non-spore-forming, anaerobic gram-positive bacilli. It can grow singly or in short chains or in long filaments. CO2 is required for the organism to grow, and it will grow on blood agar or chocolate agar. On sheep blood agar, the colonies usually appear non-hemolytic and pinpoint after 24 hours. After 48 hours, colonies may appear small, smooth, glistening, or convex with entire edges, or they can also appear large, rough, flat, with a matte surface, curled structure, and irregular shapes. Some colonies appear alpha hemolytic after a few days of growth. So you'll see the figure B of the blood agar plate. These colonies appear alpha hemolytic. Erysipeloid is also referred to as a couple other infection names, including erysipeloid of Rosenbach, erysipelotrichosis, rose disease, or fish handler's disease. This organism has been found primarily in pigs, but also can be found in poultry, dogs, cats, sheep, and fish, as well as isolated from contaminated water and soil. There are 3 clinical manifestations of erythropelothrix reuseopathiae infection, the most common one being as a result of handling infected animals or animal products. The 3 clinical manifestations may occur in humans, the first being the localized cutaneous form, also known as erysipeloid of Rosenbach, in which the site of infection is usually an abrasion or a wound of the hands or fingers. This infection is mild, localized, and self-limiting. There's also an edematous lesion that forms after 1 to 7 days, and then erythema and itching may also be present. This lesion usually heals without treatment within 1 month. The second type is a more diffuse cutaneous form, and the third is a generalized systemic infection with bacteremia. Patients with structural valvular disease, alcoholism, or other predisposing conditions may develop sepsis and endocarditis as a result of this infection. This is an infection of the hands caused by erythropelothrix reuseopathiae, and it's characterized by the blue-red patches on the skin. The next infection we talk about is one with capnocytophagia. This organism was formerly known as dysgenic fermenter 2, CDC group DF2. Capnocytophagia is a thin, non-spore-forming, non-motile, oxidase and catalase-positive gram-negative rod. When grown in culture, the colonies are adherent to the agar surface and they produce a yellow-orange pigment. Most of them are non-hemolytic with the exception of Capnocytophagia hemolytica. Clinical manifestations vary from mild to self-limiting infections to fulminant septicemia with involvement of several organs. Capnocytophagia is a normal inhabitant of canine and feline oral flora, so most patients that are infected with this organism have predisposing factors, such as having a splenectomy, patients diagnosed with cancer, and drug abusers. Symptoms of the infection include purpura, septic shock, and diffuse intravascular coagulation. The next zoonotic infection we talk about is cat scratch disease, which we mentioned briefly in previous lectures. The causative agent of this infection is Bartonella species, with Bartonella hensleyae being the most common. Transmission of this infection is via the bite of an arthropod vector, typically cat fleas, ticks of canines, or vole ear mites. Clinically, the patient presents with a mild and self-limiting disease lasting 6 to 12 weeks in untreated patients. There's usually a lesion at the scratch, lick, or bite of the animal, and lymphadenopathy with flu-like symptoms such as fever, malaise, and anorexia can occur. Now we'll move on to the next transmission route of zoonotic infections, which is direct contact or inhalation. The first organism we'll talk about that gets transmitted via the inhalation or contact route is Bacillus anthracis. So this is an organism that we've talked about a couple times before. It's the causative agent of anthrax. It's a gram-positive spore-forming rod. Anthrax has other names known as wool sorter's disease or malignant pustule. So microscopically, remember, it is a gram-positive rod. It can appear gram-variable at times and singly or in chains, and it's been described as having a bamboo appearance. Spore stains can also be done on direct samples, and those would result in positive spore results. In culture, Bacillus anthracis is a non-hemolytic colony on 5% blood agar. They appear raised, large, grayish-white, irregular, with finger-like edges, sometimes described as medusa head or as beaten egg whites in appearance. Anthrax occurs worldwide, commonly in agricultural regions such as Central and South America, Africa, and the Middle East. It's rare in the United States. Recurrences of anthrax are prevented by containing the spores and eliminating their spread through the environment. Bacillus anthracis survives well in soil that is neutral or mildly alkaline, so areas with alternating dry and wet seasons enhance the development of anthrax. Floods tend to concentrate spores which remain in the grasses after floodwaters drain. These spores have been known to last in the fields for as long as 20 years. Animals are then infected by grazing in those contaminated areas. Clinically, remember there were several manifestations of anthrax. There's the cutaneous anthrax, which is the most common form, and it also mimics a lot of other cutaneous infections. So the spores enter through abraded skin and then germinate, and then it forms a painless black eschar that heals without scarring. The gastrointestinal anthrax results from ingestion of contaminated meats. So spores germinate in the intestines and gain entry through pre-existing intestinal mucosal lesions to the lymphatics. Symptoms include fever with bloody stools, and infected persons may lose up to 12 liters of fluid per day. Most cases result in septicemia. And then there's the pulmonary or inhalation anthrax, in which inhalation of spores from contaminated meat products occur. In this infection, macrophages ingest the spores and concentrate them in the lymph nodes. The spores then germinate and sepsis occurs. With inhalation anthrax, death usually occurs rapidly within 24 hours in untreated cases. Treatment only seems to be effective if given before the onset of the respiratory symptoms. Before we look at the various treatment options, first, working up of potential anthrax includes several approaches to be considered. So depending on the patient's clinical presentation, gram stain, blood cultures, ELISA, chest radiograph, CT, and lumbar puncture might be performed. Treatment options then vary depending on the clinical presentation, and these can include orally administered doxycycline, quinolones, penicillin, and even the human anthrax immunoglobulin. Doxycycline and ciprofloxacin may be used in patients who have been exposed to anthrax but have not developed symptoms. There are also vaccinations available, but these are recommended for people in endemic areas or travelers going to these areas. The next organism we'll discuss that is transmitted via inhalation route is Francisella tularensis. That's the causative agent of tularemia. So remember, Francisella is a strictly aerobic gram-negative rod, and it causes a plague-like disease. It's a facultative intracellular parasite that grows on sheep blood agar but may appear negative early in the course of disease. It's also been seen to grow on chocolate agar, Thayer Martin, buffered charcoal, yeast extract, and also in thioglycolate broth. This organism requires supplementation with cysteine or thiosulfate for growth on successive passage. Remember, it's a non-mortal gram-negative cocobacilli that appears gray-white with raised smooth colonies after 72 hours of growth. There are two biovars of Francisella tularensis that cause infection. So type A is the more virulent form in humans in North America and is transmitted by rabbits or ticks. And then type B is the less virulent form that also infects humans, and that one is transmitted by rodents or mosquitoes. Tularemia is an acute febrile granulomatous disease, characterized by rapid onset and flu-like symptoms. Remember, there's different categories of presentations, and the most common are ulceroglandular, in which there's ulcers and lymphadenopathy, oropharyngeal, in which pharyngeal ulcers are present and lymphadenopathy, oculoglandular, in which conjunctival ulcers are present and lymphadenopathy, glandular, in which lymphadenopathy is present without ulcer, pluripulmonary, in which there's no ulcers and possible lymphadenopathy, and typhoidal, where there's no ulcers or lymphadenopathy. Of these common presentations, the ulceroglandular, oculoglandular, and glandular types usually occur as a result of direct contact with infected vertebrate or invertebrate reservoirs. Typhoidal and oropharyngeal cases of tularemia usually occur after eating contaminated food. Pneumonic tularemia is one additional presentation that can result from exposure to aerosols. Brucellosis is referred to by several terms, including Mediterranean fever, Malta fever, Gibraltar fever, Bang disease, Neapolitan fever, Cyprus fever, and indolent fever. There's 4 species that originate from animal reservoirs that are pathogenic to humans, including Brucella melitensis, associated with goats, Brucella suis, associated with swine, Brucella abortus, associated with cattle, and Brucella canis, associated with dogs. The urine and milk of infected animals contain the infective organisms. Brucella melitensis is the most common agent of human brucellosis that occurs in many areas of the world, including Mexico, Central and South America, Southeastern Europe, and countries bordering the Mediterranean, Africa, Southern Russia, India, Iran, and Central Saudi Arabia. Remember, Brucella species are small gram-negative, aerobic, non-motile, unencapsulated bacteria, and they may appear as cocobacilli or bacilli in gram smear. Under optimal growth conditions on agar, they appear smooth, raised, and translucent. Brucella are facultative intracellular pathogens that can live within mononuclear phagocytic cells. Brucella will grow on sheep blood agar and chocolate agar, and can also be isolated on modified Thayer Martin or Martin Lewis media. Growth usually appears within 18 hours, and plates should be held for 4 days before being reported as negative. Brucella are oxidase and catalase positive, and are urease positive within 2 hours. In the United States, Brucella infect humans primarily through contact with infected animals and animal products. Persons with professions that have animal contact routinely are more at risk of infection, for example, veterinarians, meat packers, and shepherds. Brucella can enter the body through abraded skin, mucous membranes, or the conjunctiva. After an incubation period of 1 to 3 weeks, Brucella are disseminated through the bloodstream, where monocytes then ingest them. Depending on the species, either granuloma or microabscesses form. So with Brucella abortus, this species usually causes granuloma, whereas Brucella melitensis usually causes microabscess formation. Symptoms of acute Brucella infection include chills, fever, sweating, weakness, and fatigue. Leptospirosis is the next zoonotic disease we'll talk about that involves contact with an animal source. So remember, leptospires are spirochetes. They measure about 6 to 20 micrometers in size. They're motile, and they have 2 subterminal flagella. and the cells can be seen on the end. So remember, another thing with spirochetes is that they can't be visualized well with routine gram stain, so specialized stains need to be performed. So this is an example of leptospires observed on a silver stain. So here you can see the characteristic hook ends on either side of the organism. Until recently, leptospirosis was not considered a widely prevalent infection. It's primarily transmitted through exposure during recreational activities, and most often is reported in the United States from the southeastern, Gulf Coast, and Pacific states, along with Hawaii. There's about 100 to 200 cases of leptospirosis identified annually, with the highest occurrence rate reported in Hawaii. So typically it's recreational activities that involve contact with water or moist soil that are usually associated with transmission. So remember, rodents and domestic animals, so particularly rats, are the primary reservoir for the organism, although other animals have been associated, including cows, horses, mongoose, and frogs that can also harbor leptospires. The organism enters through the skin and mucous membranes when individuals have contact with the contaminated soil or water with animal urine. Infections can range from subclinical to lethal. Anicteric leptospirosis is usually a biphasic disease. So when this occurs, the first phase, known as the leptospiremic or febrile phase, it lasts for about 3 weeks, and it's characterized by sudden temperature spikes, severe headaches, nausea, vomiting, and muscle aches. Patients often experience confusion secondary to dehydration. During this period, leptospires can be recovered from the patient's blood and cerebrospinal fluid. The second phase of anicteric leptospirosis is referred to as the convalescent or immune phase, and during this period, the leptospires disappear from the circulatory system and the CSF. This change occurs after the appearance of specific immunoglobulin M antibodies, so symptoms may subside for a few days, but a limited febrile episode may follow. At this point, patients can develop aseptic meningitis and severe headaches. During this stage of infection, the urine will contain leptospires, but the blood does not. At this point, infected humans can shed the leptospires in urine for up to 11 months. Another form of leptospirosis is known as icteric leptospirosis, and this is caused specifically by the leptospira interrogens serovir icterohemorrhagiae. So remember, going back to our chapter discussing spirochetes, there's over 250 biovars of leptospira. This icteric leptospirosis is also known as Wall syndrome, and this form is more life-threatening than the anicteric forms. So Wall syndrome starts in a similar manner as anicteric leptospirosis, but on the 3rd day of illness, the patient develops hemolysis, jaundice, and renal failure. So the last section we'll discuss in this zoonotic chapter is transmission of organisms by arthropod vectors. So again, we've already discussed a lot of these, but we're just going to focus on a few primary organisms. So the first arthropod transmitted disease we'll talk about is the plague. So this is an organism we've discussed before, Yersinia pestis, which is the causative agent, and it's a gram-negative rod. Rats are the natural host for the vectors, which are fleas, ticks, or other arthropods that transmit disease from one organism to another by means of bite. Humans are the accidental host. Also, remember, as I mentioned before, to make sure you're going back in your textbook to look at the various defining characteristics or biochemical tests or definitive culture workup for specific organisms. So one thing to remember, of course, with Yersinia pestis is that it's a Class A bioterrorism agent, and it has typically a distinct gram stain appearance in which it is a gram-negative rod, but it resembles a safety pin with bipolar staining. Yersinia pestis preferentially will grow at 25 to 30 degrees Celsius. So remember, when we're working up bioterrorism agents, you typically need to include room temperature plates along with body temperature incubation. Also, Yersinia requires specific media such as CIN agar or Yersinia selective agar to isolate the organism. A couple other characteristic tests that help rule out Yersinia pestis are motility. So Yersinia pestis is motile at 18 to 22 degrees Celsius, but it's non-motile above 22. And also the organism is orthonine decarboxylase negative. The transmission cycle for Yersinia pestis persists when fleas develop yersiniosis when they take a blood meal from an infected animal host. The Yersinia organism then multiply in the gut of the flea and eventually reach a high concentration that they block the flea's gut, and then this blockage impairs the flea's ability to feed, and it responds by infesting a wider range of hosts and biting more often. So humans living near rats can be infected by the fleas. Infection begins when the flea regurgitates the gram-negative rod into the bite wound during feeding. So remember, plague has two major manifestations, the bubonic and pneumonic forms, with the bubonic plague being an acute febrile disease with an incubation period of 1 to 7 days. It's usually characterized by a lesion in a regional lymph node that drains the infective area, and it results in the painful buboes that occur in the groin, axilla, or subauricular area. It is important to note that septicemic plague may occur without the bubonic form. So septicemic plague may lead to secondary pneumonia, and that's referred as the pneumonic plague. And this is always the result, mostly always the result of spread through the bloodstream of the bubonic or septicemic plague. So there's two forms of pneumonic plague, primary and secondary. Primary pneumonic plague occurs when the patient acquires the organism by infectious droplets, and secondary plague results from the plague gram-negative rods entering the lungs of the same patient who has either had bubonic or septicemic plague. With secondary pneumonic plague, there's an increased risk of person-to-person spread. And this is because respiratory droplets are produced during coughing, and these are extremely infectious. In the absence of respiratory precautions, this form may lead to a localized or a devastating outbreak. One other important thing to note is the mortality rate of septicemic plague is almost 100%, with death occurring within 1 to 3 days. Lyme borreliosis is the next vector-borne disease caused by a spirochete. So humans are the accidental host, and the disease is usually transmitted by ticks, including various Ixodes species. The white-footed mouse is the natural host, whereas the ticks are the vector. Human contact with infected rats or cats who ingest infected rats is the route of transmission for Lyme disease. So on the right is a silver stain of the spirochetes. So Borrelia burgdorferi varies a little bit from leptospiras because they are spiral shaped, but they don't have the characteristic hooked ends similar to Leptospira. The exotic tick has a 2-year life cycle, requiring blood meals to pass from the larval stage to the nymph stage and from the nymph to the adult. Nymphs and larvae feed primarily on the white-footed mouse, whereas adult ticks typically infest the white-tailed deer. The nymphs are the stage that transmit the disease primarily in the spring and the summer. And in the United States, it was first discovered or named in the Connecticut area. So typically, the organisms and higher rates of disease are seen in the northeastern United States. There are 3 stages associated with Lyme borreliosis: the early localized, early disseminated, and late persistent. But staging a patient can be difficult because the presentation varies by patient, and some may not exhibit all the stages described in the typical course of the illness. In about 2/3 of infected patients, the early localized stage is characterized by a red papule that appears at the site of the tick bite within the first 30 days of infection. This papule is referred to as the erythema migrans and is a characteristic rash of Lyme disease. So the erythema migrans can expand to form a concentric ring with central clearing, and it's described as a bullseye rash. Early diagnosis and treatment can be complicated in patients who don't exhibit the characteristic rash because they may not even remember having been bitten by a tick. Other symptoms are nonspecific and include flu-like symptoms, malaise, lymphadenopathy, low-grade fever, headache, and neck stiffness. An example of a patient exhibiting the characteristic erythema migrans lesions, and this patient actually has several on his back. In the early disseminated stage of the disease, symptoms usually occur weeks to months after infection, and during this stage, the most clinically significant symptoms are neurologic, such as Bell's palsy, neurologic deficits, and meningitis. Other symptoms that may appear include oligoarthritis and carditis. The late stage, or late persistent, Lyme borreliosis is characterized by relapsing arthritis that occur months to years after the initial symptoms. The joints most commonly affected are the knees, shoulders, and elbows, and untreated patients may have decreasingly severe attacks with time until symptoms eventually disappear. Treatment and management of Lyme disease are guided by the patient's clinical presentation, stage of the disease, and the presence of any allergies. Rickettsia species are the next arthropod-borne organism we'll discuss that causes different types of rickettsia infection, included the spotted fever group and the typhus group. So the rickettsia organism are short non-motile gram-negative rods that are obligate intracellular bacteria that can only grow in the cytoplasm of host cells. So the arthropod hosts serve as both reservoirs in which the organism is transmitted transovariously and as vectors, because the organism is transmitted between mammalian hosts. Rickettsia can be grown in culture, but it requires cell line culture to be grown, and because of the infectious nature, any attempts to cultivate them in clinical labs without proper equipment and training is not recommended. So usually this would be isolated in specialty labs. Rocky Mountain spotted fever is one of the forms of disease caused by rickettsia in the spotted fever group. So with this presentation, the disease is transmitted by, or rather it's caused by, Rickettsia rickettsii and transmitted by the Dermacentor variabialis and Dermacentor andersonii ticks. In this infection, incubation occurs about 7 days, the patient presents with flu-like symptoms, and these include fever, headache, myalgia, nausea, vomiting, and rash. The rash begins as a red patch on the ankles and wrists during the first week of symptoms, then extends to involvement on the palms of the hands and soles of the feet. However, it normally will not affect the face in this type of infection. The maculopapular patches eventually consolidate into larger areas of redness. Other symptoms can include hypotension and disseminated intravascular coagulation. The Rocky Mountain spotted fever group is the most severe of rickettsia infections. Bhutanese fever, also known as Mediterranean spotted fever, is another presentation part of the spotted fever group, and this is caused by a different species of rickettsia, Conoriae, and this occurs primarily in France, Spain, and Italy. Similar to the agent for Rocky Mountain spotted fever, this rickettsia is tick-borne, and its reservoirs include ticks and dogs. Bhutanese fever is clinically similar to Rocky Mountain spotted fever because it causes a rash that commonly involves the palms of the hands and soles of the feet, but unlike Rocky Mountain spotted fever, the rash may also involve the face. An infection may be marked by a symptom known as tache noire, which is a small black centered ulcer that appears at the site of the bite. Other symptoms associated with Bhutanese fever include lymphadenopathy, but it's typically considered milder than Rocky Mountain spotted fever because the fatality rate, even without treatment, is much lower. Rickettsial pox is the last presentation we'll discuss as part of the spotted fever group, and this is caused by Rickettsia acari. This occurs in Korea and Ukraine, as well as in the eastern United States. This presentation is also similar to Rocky Mountain spotted fever, but milder. The reservoir is the common house mouse, and the vector is the mouse mite. After an incubation period of about 10 days, a papule forms at the site of inoculation. The papule will progress to a pustule and then to an eschar. Other symptoms associated with rickettsial pox include headache, nausea, and chills. Unlike Rocky Mountain spotted fever, the rash of rickettsial pox appears on the face, trunk, and extremities and does not involve the palms of the hands or soles of the feet. And rickettsial pox symptoms will resolve without medical attention. Of the typhus group, rickettsia infections, the endemic typhus is caused by Rickettsia typhi. The vector associated with this infection is the oriental rat flea, and the rat itself is the reservoir. The cat flea can also serve as a reservoir. Another name for endemic typhus is murine typhus. The clinical course is similar to Rocky Mountain spotted fever. It includes headache, fever, and rash, but unlike Rocky Mountain spotted fever, rash appears in only about 50% of the patients. When the rash is present, it's usually only on the trunk and extremities. Louse-borne typhus is caused by Rickettsia prowazekii, and vectors of this presentation include the human louse, squirrel flea, and squirrel louse. The reservoirs are primarily humans and flying squirrels located in the eastern United States. Unlike vectors of other rickettsia, the louse often dies as a result of the rickettsial infection. When the louse feeds on another human, it defecates and the infected feces are scratched into the skin. Disease progression then resembles that of Rocky Mountain spotted fever, including a rash involving the palms of the hands and soles of the feet. But unlike Rocky Mountain spotted fever, the face may also be affected by this rash. Mortality rates in treated patients are very low. However, rates for untreated patients can approach 40%. Brill-Zinsser disease, or recrudescent typhus, is a reactivation of louse-borne typhus. The Brill-Zinsser disease presentation is milder than louse-borne typhus, and patients with these latent infections are an important reservoir for the organism. The last zoonotic infection we'll discuss is from the family Anaplasmataceae. So the members of the genre Ehrlichia and Anaplasma are the most important pathogens in this family. Characteristics of these organisms include that they are intracellular parasites that multiply in the phagosomes of host leukocytes and not in the cytoplasm of endothelial cells. In addition, they are not transmitted transovarially in ticks. Ehrlichia, similar to chlamydia, possess an infective form known as the elementary body, which replicates in the phagosome. The infective form of Ehrlichia divide to form a morule, which is a mulberry-like body that can be observed in the cells microscopically. The host cell ruptures as an effect, and the morulae break into many individual elementary bodies that continue the infective cycle. Human monocytic ehrlichiosis is a seasonal disease, with the majority of cases occurring during the summer months of June and July. This infection does occur worldwide. In the United States, though, most cases are found in the southeastern and south central states, as well as in the mid-Atlantic states. The causative agent of human monocytic ehrlichiosis is Ehrlichia schaffensis. The natural hosts of the organism include dogs and deer, as well as humans, with the Lone Star tick being the primary vector. Anaplasma phagocytophilum, which was formerly known as Ehrlichia phagocytophilum, causes the disease now referred to as human granulocytic anaplasmosis. The natural hosts of anaplasma include deer, rodents, horses, cattle, and humans. The tick vectors include Ixodes species. In human ehrlichiosis, organisms have an incubation period of 5 to 10 days. Disease is clinically variable, but most patients have a moderately severe febrile illness, with the most frequent manifestations being malaise, fever, myalgia, and headaches. Some patients have arthralgia or involvement of the gastrointestinal tract. Rash can also be observed in a small percentage of patients. Some of the least common symptoms associated with human ehrlichiosis include nausea, vomiting, diarrhea, cough, joint pains, confusion, and rash. Although human monocytic ehrlichiosis and human granulocytic anaplasmosis can appear clinically similar, there are some differences aside from the causative organism varying. So with human granulocytic ehrlichiosis, there's a couple things that are more specific to this presentation. As many as 60% of pediatric patients infected by Ehrlichia schaffensis may have a rash, although adults with the same infection rarely experience rash. Patients may also have evidence of leukopenia, thrombocytopenia, and elevated liver enzyme levels. Severe complications can occur, such as toxic shock-like syndrome, central nervous system involvement, and adult respiratory distress. The The last topic briefly discussed in this chapter covering zoonotic diseases are emerging zoonoses. So in recent years, the significance of zoonotic infections has continued to grow because of the emergence of several large-scale outbreaks in humans and animals. Population growth is a significant cause, as the worldwide population has more than doubled in the last 50 years, leading to changes in land use, urbanization, and use of raw materials, which have forced humans and domestic animals to move into previously unpopulated areas. And it's also caused the wild animals to change their migration patterns and share their habitats with humans. In addition, international trade has increased due to demand for animal products and meats, which also plays a role as the interactions of microbial exchange among humans, domestic animals, and wild animals has increased over time. Although not all-inclusive, some of the emerging outbreaks have included the SARS outbreak in 2003 and the avian flu outbreaks in 2003 and 4, the swine flu in 2009, and then in 2010, the E. coli outbreak in sprouts. Some of these emerging zoonoses will be covered later on in our virology chapter, but there's other bacterial ones that we've discussed that have already become agents of concern. Zoonotic infections represent a significant percentage of the workload in the clinical microbiology lab, and for the past 30 years, emerging infections have been recorded, including the discovery of some unknown pathogens, and of these, about 75% have been of zoonotic origin.